Our next panel of guests will discuss healthcare disparities, health equity, and access. Please welcome Dr. Elena Rios from the National Hispanic Medical Association, Donna Cryer from the Global Liver Institute, Kevin Hagan of the PAN Foundation, and Douglas Hoey of the National Community Pharmacists Association. They are joined by the Hill's Bob Cusack.
Hey, thanks for a great panel here. Got a simple question for you. You got to answer each in 2 minutes. Okay. What keeps you up at night on healthcare? What are you worried about the future of healthcare? Elena, let's start with you.
Well, I think we learned a lot of lessons from COVID-19, and one of them is that our community has a lot of essential workers that can't go home when there's a pandemic. And, you know, the Latino families, overcrowded, language issues, immigration issues, generational issues, acculturation issues. I think for us, the National Hispanic Medical Association, we're constantly trying to find more Spanish-speaking doctors and Latino doctors or Latino-serving doctors that can talk about the information in a way that is resonant to our communities. And I think that's what really keeps me up at night. It's so important to just get down to basic information to our communities.
Pretty good answer. Donna?
So I view things through the lens of a transplant recipient and a leader of an organization responsible for many people in end-stage disease. And so I am preoccupied with making sure fewer people end up needing the level of care that I did, that saved my life and sustains me today. And so as we've talked about all the issues today in prevention, in connecting to primary care, in making sure that we're dealing with whole person care and survivorship, those are all the things really that will keep people well and have fewer people need the catastrophic levels of care that I've received.
Kevin?
I would say, you know, at the PAN Foundation, a lot of our patient population skews slightly older, Medicare age population. And I would say what keeps me up at night really comes down to sort of 3 words. First is access, second is education, and then the third is the need. One, making sure that patients have access to the therapeutics that they need to have their life and quality of life and life extended. I would say, particularly around education, for our Medicare population, there have been some positive changes with the implementation of the Inflation Reduction Act and the Part D Medicare reforms. In 2025, there'll be a $2,000 cap on out-of-pocket costs, and that's great for the patient population. But at the same point, they need to be educated around it because there are some provisions that are involved in that law, like cap and smoothing, that are going to be opt-in provisions. And I think the education of patients as well as physicians and healthcare providers to help assist those patients is going to be really critical moving forward. And then finally, I would say need at the end of the day in terms of patient need. My biggest concern is that when out-of-pocket caps go into effect for our population, the world's going to think, oh, $2,000, anybody can afford that. But we know that's actually not the case. I mean, our own polling shows that 75% of older population actually says that $2,000 is a real stress on them. Mm-hmm. And that number jumps up to 86% when you look at a Black population and 82% when you look at a Hispanic population. So those are really the 3 things that we're constantly thinking about and I think keeps me up at night.
Doug?
Yeah, thanks, Bob. So for the community pharmacists, we were there, about 20,000 independent community pharmacists in the country, and we were open during the pandemic even when others were not. And so we see patients coming in all the time and have a front row seat into the healthcare system. I'd say the 3 things that keep our members awake are costs, waste, and access. And so the costs of paying for prescriptions, but also the bureaucracy that's associated with it. And with that comes the waste. There's a tremendous amount of waste in our healthcare system, and our pharmacist members have a front row seat to that. And sometimes are very frustrated because they can't affect that wasteful spending that they're seeing before their eyes. And the last thing is access, and that has to do with costs and waste as well. And not only the access to the care, but access to the information, access to the services that are out there, but patients may not be aware of them. So those are the three things: cost, waste, access, that keep us awake.
Where are we, Doug, on drug shortages now, post-pandemic?
Yeah, drug shortages are on the increase. They continue.
Why is that?
It's a variety of reasons, including some of the access to the active pharmaceutical ingredients, the API, which are mostly offshored. So the vast majority of our API comes from China and India, so we're very reliant on that, and I think we're very vulnerable to that. Another thing that's not talked about a lot is that some generic products, many generic products, have gotten to be so inexpensive, even though some PBMs will charge a higher price for these inexpensive drugs, but they've gotten to be so inexpensive that some generic manufacturers are getting out of the business and saying, I can't afford to make this. It's not profitable for me to make a $2 bottle of effective medicine. I'm out. And we're seeing more and more shortages, especially with antibiotics, cancer drugs. But it's a big concern, the increase we're seeing in the shortage of drugs. And there really needs to be some thought around how do we prevent that from a sourcing standpoint for the API, but then also reforming the payment model so there's incentives not only for the generic manufacturer, but everyone in the supply chain to make sure these generic products are available.
Kevin, you mentioned the Inflation Reduction Act, and as you know, that was a lot of sausage making. There was a lot of controversy around that legislation. Now there's legal action regarding the Inflation Reduction Act. Number one, do you think that the healthcare provisions will hold up in court? And number two, are you hopeful that Congress, because a lot of Democrats said that was only step one. They obviously wanted to do more, but they couldn't because they didn't have the votes. Just tackle those two things if you can.
So I will never predict what a court is going to do. I've had my share of interactions over the years leading a variety of organizations. So courts to me are always unpredictable. I'm not going to make any predictions around whether they're going to hold up or not. But I would say what's really critically important for us, I mean, you're talking about there needs to be more done, and I would say that from the PAN Foundation perspective, we're always looking at what's in the best interest of our patients. And for us, what really matters is their therapeutic accessible when they need it, and can they afford to do it? So for us, I mean, drug pricing, as you all know, is an incredibly complex web of activities and players. But for us, it really comes down to what's paid by the patient out of pocket at the pharmacy counter. So for us, that's what we've tried to focus on, is what are thoughtful and meaningful reforms and changes that can happen that actually help patients better afford those prescriptions. Particularly because it's not just sort of our population, which tends to skew a little older. We do have a sizable number of patients that are living with rare diseases, and those rare diseases also have higher out-of-pocket costs. So I would say most of our advocacy efforts have really been around trying to figure out what makes that more affordable, which I think is one of the reasons PAN spent so much time and energy really advocating for out-of-pocket caps, as well as things like cap and smoothing. This cap and smoothing provision it can be a game changer for patients because it allows them to basically take their out-of-pocket cost and if they need the drug in January, divide it by 12. So they're not getting this hit at the beginning of the year for out-of-pocket cost. And we think that this is a real opportunity, but it also requires a tremendous amount of education and requires opting in. Which means everyone needs to get familiar in the healthcare system around what that looks like and how patients can access it.
Donna, we were talking a little bit backstage, speaking of education, we're talking about educating patients, and a lot of times, well, most times, you're not educated on a topic unless you are diagnosed with one, or possibly, and then you go online and you worry about things. But what, I wanted you to kind of talk about the education of patients who need organ transplants. And it's not as simple maybe as it may seem. Can you talk about that? I know you're obviously very familiar with this. Yes.
Absolutely. So one, we are in an information climate that is rife with misinformation. And so it's a great privilege to be working with the National Academy of Medicine and WHO and many others to help to solve that, so that anything that we put out as a patient advocacy organization working with medical societies will stick with people, that it's not in the noise of all of this misinformation. So that's a major problem that all of us face and have a responsibility to confront. Around transplantation, many people think that it's just moments and miracles, and it certainly is, but it really is more about prevention, having access to primary care so that you can get a referral to be listed for transplant, to make sure that organs are available. And we've been working with Congress in a very bipartisan way to have reform of the organ procurement system. And CMS has been moving forward with that, and so we're very grateful for the administration standing up really on this issue that it's sort of the issue of my lifetime, because 20 some years ago when I was first transplanted, we recognized that this was something that needed to happen, and so maybe I can retire now if we can get this done. But also we have issues of availability from living donors as well, which is responsible for a lot of the growth. And we know that there's a Living Donor Protection Act that is being put forward. And so I think that this is in some ways the golden age of innovation and access and hopefully equity in transplantation, if we can make things happen. And it's really the simple blocking and tackling things. It's not, there are so many large challenges that we don't yet know how to solve. In liver disease and in transplantation, we do know how to solve them. We just have to have the will. We need to actually give people hepatitis C cures, as Dr. Collins has come out, and so many members of Congress, Senator Cassidy is certainly working to help. We need to make sure that people have the obesity medications. NASH is one of the key drivers of transplantation. We need to make sure that they're vaccinated against hepatitis B. I mean, it's a wonderful problem to have, that we know what to do. We just need the will to do it.
We'll be opening up for questions in about 5 minutes or so. And I want to talk to you about, speaking of health equity, Dr. Fauci talked about it earlier. Where are we, and what has worked, and what do you think policymakers should do, whether that's the administration or Congress or states, to improve it, to make, and maybe talk a little bit about progress we have made, but where we need to go?
Yeah, I think the Biden administration has really done a great service to the country by having health equity plans in every agency, every program that the federal government has. So, and there are more focused efforts on health equity than ever before in climate change, for example, just our environments, obesity, the way we live, and language. The Office of Civil Rights is now making it discriminatory for our federal funded hospitals, clinics, medical practices. They have to have language services now. But I think one of the most important things, this is the 5-year reauthorization of the workforce. The workforce shortages in this country are amazing in healthcare. Doctors, nurses, pharmacists, dentists. And one of the biggest things we can do is recognize, and from the Latino perspective, the 2 largest school districts in the country, Los Angeles, 75% of the Los Angeles Unified School District are Hispanic. New York City's school district, over 40%. That's our workforce. Our workforce in this country, we're going to be 1 out of 4 Americans in the next 10 years, Hispanics. And I think we need to stop ignoring our community and give more counseling and mentoring from our organizations like the Hispanic dentists, Hispanic nurses, Hispanic pharmacists, Hispanic medicine, because we're the alumni of the schools of this country that made it because of affirmative action, because of financial aid in the 1960s. We're the first generation of professionals in healthcare, and we should be the deans of the schools. We should be the faculty. We should be on the boards of trustees of these universities. And why aren't we? Because we're just figuring out how to help each other with leadership development. But getting back to policy and your question about health equity, I think the shortage will be changed if we can have more residency slots for more doctors to be trained in this country, and more community-based clinics and the children's hospitals getting their funding, and also that we have more language training, medical Spanish in medicine, nutrition training in this country, and that we have more physicians working together to be a doctor, to want to take care of their patients and not just go by the rules of insurance companies or the rules of the industry in general. And I know that that's happening, but we just need you to know that the National Hispanic Medical Association is very excited about building our organization.
That's a great topic on the workforce issues. We have an aging population. We have Medicare headed for bankruptcy. We've got, especially after COVID, we've had shortages of healthcare practitioners. Anyone else want to join in? Like, what do you think about, Donna, like, where are we going in that issue? Because we need people to take care of this aging population.
Absolutely. I think that Elena is absolutely right in terms of the virtuous cycle that comes from having more healthcare practitioners at every level, from techs to surgeons, who come from that community. Then you have not only jobs and an economic engine, but you have more people who can deliver in language, culturally concordant care. So it's not just about solving the issue of better health outcomes. That would be good enough, but you've really created a virtuous economic cycle within communities and enriched it with people who understand and can talk and be the translators for their families and explain health issues. So you've really addressed the problem in so many different ways by building up a workforce from the communities, for the communities, and then I want to make sure you underscore this point, and then making sure that those folks are on the boards of the hospitals and are in charge, deans of the schools, and are in charge, because ultimately this is about power and who gets to make the decisions and who sets the agendas. And if more people from the communities are the people who help set the agendas, then the agendas will better reflect the needs of those communies.
Kevin, regarding, go ahead,
real quick, I think
jump in.
that just healthcare jobs, we need to make them, I mean, they've become unglamorous jobs, in my opinion. I mean, you have doctors, which has always been Marcus Welby, ER, tons of doctors. I mean, that's been a very glamorous, and it probably still is, but I think, my son's 20, he's not going into healthcare, he's going into technology. That's the glamour job right now. And I think part of the problem is the payment system that just bogs down and makes it harder for patients. And it just, when a young person sees that, they're like, I don't want to do that. I want something that's more interesting. So I think we have an image problem in all healthcare, and we need to make that, we need to reform that and just show how we're helping patients and that there is a lot of satisfaction. But I know in pharmacy that there's a lot of unglamour, if that's a word, and that needs to be reformed through payment reform.
And your son has no interest in going into healthcare?
No, I've got 2 more kids after him, so we'll see.
Well, I've got 3. They all want to go into healthcare. I have no interest in journalism, so maybe they see my hours. Kevin, your thoughts just on that, and also I wanted to touch upon healthcare innovation. You've been in the healthcare field for a long time. What are you kind of excited about? I also want to kind of talk about positive things going forward instead of all negative things.
Yeah, so just in terms of sort of the workforce thing, less specific to PAN, but I was the former CEO of the American Diabetes Association before coming to PAN, and clearly, workforce shortages, there is a massive shortage and has been for many, many years of endocrinologists in the United States. So I think you're spot on in terms of the glamour of it. It's not perceived in the way that I think it was to be in healthcare, 20 years ago. When we were at ADA, we started a fellows program where we intentionally tried to lure people in to specializing in diabetes. So, I think there are definitely challenges on that front. In terms of innovation, it's interesting. There's so much going on in healthcare. I mean, from just therapeutics with gene cell therapy or gene therapy and cellular therapy. But there's also, we have, everybody's been hearing about AI lately, and, now there's starting to be commentary around how AI is getting used in medical practices and healthcare in general, and making determinations about prior authorizations. So I think there's an interesting positive horizon out there, particularly around technology and the use of some of these burgeoning technologies. But I also want to be reasonable and cautious that we do train and have specialized healthcare professionals for a reason, and I think the balance of those tools with the expertise of people who have deeply studied this is going to be critically important going forward.
Got a few minutes left. Let's open it up to questions. If you can raise your hand, and staffers will come to you with a handheld mic, and if you can identify yourself.
Hi, thank you so much for talking. I'm Dr. Ashley Tucker. I'm a postdoctoral research at the NIH. And so I've had the opportunity to train many undergraduates that are so excited to go into medicine and apply into medical school. But it seems like so many of, to actually apply to it, there's so many things you have to be. You have to get certain grades. You have to almost cure cancer at some point to get into medical school. Do you think we should actually be lowering the standards to get into medical school so that we can address these shortages and also provide more diversity in these schools?
No, you can't lower the standards, but that does not conflict with increasing diversity. There are, as a daughter of a science teacher, I can attest that there are brilliant children of every community, of every ethnicity, who would do well in medical school. It's about support, it's about tuition support, it's about supporting careers. I've had lovely conversations with Governor Green of Hawaii about the program that he's doing to be able to forgive loans. So I think we need to be more creative about supporting medicine, but as the person who's lying in the bed, I'm just gonna say, no, we have to keep the standards very high. Medicine is not one where we can lower the standards. What I wanna say about innovation is, though, where I find so many of the energetic med students and fellows and even burnt out physicians are in innovation hubs. And we love working with them on innovative projects of patient-centered research on things like digital pathology to replace biopsy. There's so many wonderful things happening. 3D printing of organs. We're about to change paradigms in terms of tolerance of immunosuppressants. So maybe you don't need immunosuppressants like I do. So there's so many exciting things going on. I wouldn't want anybody to miss it, but you do have to do all the work to get here, but we'll support you through it.
Anyone else have a question from the audience?
Thank you guys so much. And I totally agree about the importance of increasing diversity in medicine. I plan on going to medicine. I just graduated from undergrad. My question relates to sort of the liver a little bit, but I think anyone can answer it. I actually did research in liver regeneration. And something that I saw pretty often is that because the etiologies of liver disease relate to some lifestyle choices, whether that be the use of syringes or the use of alcohol, a lot of the conversation is normative in that you did something that I wouldn't do, something bad, and so you have this disease. And then that's why we see a lot of inequity, because we don't feel called to act when someone's behavior seems like it contributed to the disease. So my question is, as physicians or policymakers or just people who are interested in health in general, what can we do to sort of change the conversation to be less judgmental and less normative, so that there is sort of an incentive to make great strides in health equity?
Well, I'll volunteer to take all of the celebrities that were in that Creative Coalition ad earlier to do a liver campaign. I think that would help. But you're absolutely right. I think there is a false narrative that all liver conditions come from alcohol or something self-induced. And that's not true. There are more than 100 different types of liver diseases. My transplant was caused by an autoimmune disease that started when I was in 8th grade. And so I think that narrative needs to get out. And stigma is the biggest issue that keeps us from being in policies, in conversation, of people valuing us and caring about us. And so we confront it head on by having people meet our patients and actually learn about the science. And so I accept your volunteering with our organization, the Global Liver Institute, and we'll follow up with you afterwards. But I enlist all of you to help us change the narrative. All of you know someone who, well, all of you have a liver. So all of you are at risk of some form of liver disease. And so whether it's a child with biliary atresia or a young person with an autoimmune disease or a veteran with hepatitis C or a grandparent with liver cancer, we can't meet our goals of the cancer moonshot without solving liver cancer. All of you have a role to play.
Well, we've run out of time. Great discussion. Please thank our panel.